Today my talk about RECIST criteria, the latest version 1.1. So RECIST criteria mainly can focus on how assess the tumor response compared with the management therapy, any therapy including chemotherapy or even intervention therapy. So if we go to the past till the year of 1981, when the World Health Organization tried to establish a new criteria used by radiologists to establish a system, a fixed system and parameters to follow up the tumor response to the therapy. These criteria based mainly on tumor dimensions by taking the shortest diameter of the lesion in addition to the longest diameter of the lesion and summation of both diameters, leading what we call two products, leading what we call sum of the product of diameters, or what we call SPD. This principle used since 1981 till the 2000 and was implemented for many years in many clinical trials and any assessment of new drugs for oncology management. Also, World Health Organization categorized the tumor response into main 4 categories. Category number 1, complete response, which means tumor completely vanished at least for 4 weeks. The other group, partial response, when there is reduction of 50% of the size of the tumor, confirmed at 4 weeks. Category number 3, progressive disease. It means there is increase of the SPD diameter or summation product diameter equal or more than 25% compared to the basal study. And the stable disease, it means that there is no progression, no regression, or partial response. Based on these criteria, contained for more than 10 years, implemented in many clinical trials, and implemented in assessment of new chemotherapeutic drug agents. However, after its assessment, again, especially at the year of 2000, they found that these principles need to be modified. Simply, these principles show false progression of the disease, because if there is a tumor lesion like that and there is just increase 5 millimeter in both shortest diameter and longest diameter, it will produce 25% increase, and this is mean a progressive disease. And what's meant by progressive disease? This means failure of the current treatment. And this is not the situation. The real situation could be hazard to the effect of the drug. So in 2000, in the year of the 2000, 4 international organizations, including WHO, European Organization of Research and Treatment of Cancer, National Cancer Institute of the United States, and the National Cancer Institute of Canada, they made a group summit and established a new criteria named as RECIST criteria. And these criteria has a different principles and different terminology and different definitions and different concepts. They define target lesions, measurable lesions, non-measurable lesions, and modify the standard categorized response of the old one. So this new version is called RECIST version 1. It was contained till the year of 2009 and showed very successful and wide acceptance from both radiologists and oncologists in the field of the oncology tumor. However, in 2009, and after implementation of large clinical trials, including about 6,500 patients and about 18,000 target lesions, they found these criteria need to be modified. And from this year, 2009, a new version of RECIST criteria established and became 1.1, version 1.1. And this table highlights the main difference between the three main systems since 1981 to the 2009 and above. WHO based only what we call SPD diameter. However, in RECIST, found the most predictor assessment of the tumor response is the longest diameter of the lesion, not the longest and shortest, both of them, but longest diameter of the lesion is the best predictor for the tumor response. In RECIST 1.1, they found also the longest diameter is still this concept used, but in the lymph node assessment, we should use another diameter, which was the shortest diameter. And we will discuss this in details. In the older version, there is no limit of the number of lesions in WHO. However, in RECIST version 1, they limit lesions up to 10 lesions in the whole study, 5 lesions per organ. In last version, modified and reduced to 5 lesions in the whole study and 2 per organ. Lymph nodes included only in the last version, 1.1, and progressive disease, it changed from 25% or more and became 20% or more. And any appearance of new lesion considered as a progressive disease. So this is the timetable for the response system developed from 1981 to the 2019. This is the RECIST Guideline, which published in 2009 in the European Journal of Cancer, which describe in details the latest version of RECIST criteria 1.1. So to apply the RECIST criteria, latest version, you need to at least one measurable solid lesion in the basal study. Also baseline exam maximum up to 4 weeks prior start to treatment. Follow up with the same examination protocol. That means that if you start with CT, you should follow with CT, and if you start with MRI, you should follow with MRI. IV contrast is required. Oral contrast is recommended but not mandatory. As I have mentioned before, there are new definitions and new terminology we will discuss in details. They are developed target lesion and the non-target lesions, measurable lesions and the non-measurable lesions. So what are the target lesions? Target lesion, it means that any lesion, longest diameter, 10 millimeter or more. This could be selected as a target lesion. Below 10 millimeter, it's not measurable. This is a non-measurable lesion and couldn't be selected as a target lesion. And target lesion, it means this lesion, you will select it to be followed in the following exam. So this is your target. Also, in the latest version, they introduced the importance of the assessment of the lymph node. And the lymph node differs because we based mainly on the short axis of the lymph node, not the longest axis as the solid mass lesions. And the cutoff value of the shorted axis to be target lymph node, it's equal or more 15 millimeter. Also, any osteolytic lesion could be a target lesion if it is associated with a soft tissue mass lesion equals 10 millimeter in the longest diameter. However, if there is osteolytic lesion or any bony lesion without soft tissue lesion, so it's not a target lesion. We cannot measure it. The idea of RECIST to select 5 organs per whole study and make summation for the longest diameter, either solid organs or the lymph nodes, and this the summation of this number, it will be the basal, which will be followed up in each exam. And we'll see some examples, we'll discuss it in details. So what are the non-target lesions? Simply non-target lesions, it's non-measurable lesions because it's less than 10 millimeter. Also, any lesions couldn't be measured, like ascites, pleural effusion, osteolytic lesion without soft tissue component, peritoneal carcinomatosis. All these we cannot measure, but it should be mentioned in your reports and should be followed up, presence or absence, but not by size. Here is the example of axial cuts of the lung window. The white arrows indicate there are multiple pulmonary nodules. They are solid nodule, and the average longest diameter 5 millimeter. So these nodule less than 10 millimeter, so it is non-measurable and a non-target lesion. Of the same patient on another level, we find that one large lesion measures about 14.6 millimeter. So this is a target lesion. This is mean that this lesion, we will follow it in the future exam. This is example of medullary deposits and the medullary shadowing, minute foci, below than 10 millimeter. So this is a non-target lesion, but of course you should mention in your report. This is example of non-target lesions and the non-measurable lesions, ascites, bilateral effusion, and bony lesions. So remember, measurable lesion, remember target lesion should be measurable lesion. However, not every measurable lesion could be a target lesion. Because we are stick in the rules, you will select two solid nodules or two solid mass per organ, and the 5 per total study. And the non-measurable lesions, it will be less than 10 millimeter. This is example of hypodense hepatic focal lesion in the right liver loop. And when we measure the longest diameter, remember always we measure the longest diameter. So we can simply try the 2 dimensions and take the largest one. This is the longest diameter, so this is the target lesion, and this is the only lesion we have in this study. So we don't have option. We should choose this lesion and the follow-up in the future exam. This is a pancreatic tail lesion, measures about 56 millimeter. And we measure also the longest direction. Remember, the longest direction, not the shortest direction. This is another example of the liver, 43 millimeter, solitary lesions, and all these considered as a target lesion, and in the lung window. Also remember that when you have a lesion in the lung, you should measure it in the pulmonary window, in the lung window, not in mediastinal window. And simply you can notice this. This is the same patient and the same level of the lesion. The here measure about 23 millimeter, and the here measure about 17 millimeter. So there is a big difference. So when you'd like to measure a lung nodule, you should measure in the pulmonary window. So what about lymph node? As we said before, lymph node, you should measure the shortest diameter, not the longest diameter. So we have a multiple case of, this is aortocaval lymph node and retrocaval lymph node, and there is aortocaval and left paraortic. So lymph node, the lymphatic system, you would consider them as a one organ, as a liver, as a lung, one organ. So you stick to the rule, 2 lymph nodes, you will select them, just 2. Even if you have 100 lymphadenopathy, but you will select 2 target lymph nodes. So in this case, we select the aortocaval lymph node, and we have 2 dimensions, 20 millimeter and 23 millimeter. So this is lymph node, so we'll rely on the shortest diameter, not the longest diameter. So this is the right axis diameter. Also, this is 11 millimeter, so it considers one of the target lymph nodes. So in this study, so if I decide to choose these 2 lymph nodes, so I have 3 lesions. to fulfill this criteria, if they are present, of course. Okay, let's come how to measure the target lesion, especially in the following examination. This is the time point 1 of the basal study. We found that a hypodense focal lesion in the liver measures about 14.6 millimeter. And we take this is the longest diameter. Okay, at the time point 2 or the future exam, we can notice that there is a change of the shape of the lesion. And this is a very common as a response of the treatment. So the question is, shall I measure the lesion with the same direction of the basal study, or searching for the longest diameter, whatever the shape of the lesion, either it changes or not? And the answer simply should be follow the rule. The longest diameter, even if it differs from the previous study. So we have 3 choices here. The right choice 1 here. I should measure this lesion in the longest diameter like that, not like that, or not like that. Another pitfall we should be careful about when the lesion became adjacent to another structure, like a vessel. This is a case of the pancreatic lesion. We can notice in this, there is a hyperdense vas vessel here. So be careful when trying to measure this lesion to take in your consideration or take it inside your measurement, because it will signify a few millimeter, but it will have a reflect on your final decision and in your follow-up. Second question, how to select the lesion? We know that how to measure the lesion, how many lesions we showed it to have. So how to select the target lesions? There are some pitfalls to try to select the lesions. Always try avoid 2 neighboring lesions, because in many situations in the follow-up of the treatment you will find them make coalesce with each other, and so in this situation you will lose the target lesion which you follow from the basal study. So try to choose a separate lesion away from the other lesions, like those examples. Also try to avoid the periphery of the lesions, because in this case, maybe in the future exam by respiratory movement and motion or any misregistration, this lesion is disappear or its size will be reduced. But this is not the actual current status. So be careful, try to avoid the peripheral lesion and the neighboring lesions. This is an example of multiple hepatic lesions. In this case, I will not choose those 2 lesions because they are very close and almost they will coalesce to each other. Also, they are periphery here, and this is periphery here, so I will try to avoid them as I can. This is a case of colon cancer metastasis, but here we can choose this one. It's away, surrounded by a good parenchyma, so I can choose it safely. And remember that you will follow this patient, so make your life easier in the next exam and don't trouble yourself. So this is regarding the lesion. So what's regarding tumor response categories? Tumor response in target lesions divided to the 4 categories. Complete response means disappearance of all target lesions. So if you have 5 or 2 or 3 target lesions and followed up in the next exam and you find them disappear, so you achieve a complete response status of the patient. With one condition, if there is a lymph node, should be the shortest diameter less than 10 millimeter. This is meaning of complete response. So what about partial response? Partial response, it means decrease in the summation of the whole diameter of the target lesions by 30% or more. Progressive disease, it means increase the summation of the diameters of the target lesions by 20% or more. In addition, the total summation increased by 5 millimeter compared with the previous study. stable disease, neither partial response, nor neither progressive disease. And in any event, even if there is significant reduction of any lesions, of any target lesions, however, there is appearance of any new lesion, this is considered a progressive disease. So regarding the non-target lesions, also have its schedule for definition. Complete response means disappearance of all non-target lesions, and here we may need a tumor markers. If there is high, it should be normal. And in some situations and in some cases, we cannot find target lesions. We cannot find sizable lesions 10 millimeter or more. So we are rely on the non-target lesions. So in this case, we will use this table because we don't have target, just non-target lesions. So we will rely only on the non-target lesions. So this is the meaning of complete response regarding the non-target lesions. Non-complete response and the non-partial response, it means maintain of the high tumor marker and the persistence of one or more non-target lesion. Also progressive disease, it means unequivocal progression of the non-target lesions or appearance of new lesions. And unequivocal progression means despite the presence of a stable disease or partial response. So if we take a live example to know how we can follow these cases. This is time point 1 or basal study. So we have different lesions here, but I have selected these two lesions, one 17.2, we can say 17 and 90 millimeter. So SOD1 we call summation of diameter in point 1, 19 plus 17 equals 36, and in the future exam or in the next exam, I follow this the same lesions, but I found that 17 became 24 and 19 became 30 millimeter and SOD2 became 54. So by this equation, we can calculate the amount of increase, and this equals 50% increase. So this is mean progressive disease because the criteria or rule determine 20% plus absolute 5 millimeter increase. This is mean a progressive disease. So we have, instead of 20%, we have 50% increase, and we have 36 millimeter in the basal study, and became 54 means increase more than 5 millimeter. So this is an example of progressive disease. Another example, this is two cuts, time point 1, and this is time point 2. This is example, this is the lesion 4.6, and another lesion in different level 5.4. So SOD1 equals 10 centimeter. In the next exam, there is reduction 3.3 and 2.7 equals 6. So there is 40% reduction. Regarding to the rule, 30% reduction, it means partial response. So 30% or more partial response, and here 40%, this means that partial response status. Another example here, this is the case which we shown before. This is a pancreatic lesion, and we have hepatic focal lesion, and the pancreatic lesion, and the lymph node. So we have 3 target lesions. In this study, we have 3 target lesions, and SOD1 in the basal study 105 millimeter, in SOD2 equals 79 millimeter, and difference just about 3%. So this is no significant change. This is considered a stable disease because it doesn't achieve to 30%, you can say a partial response, or doesn't reach to 20% to say 20% increase to say this is a progressive disease. These are the table which summarize the different scenario. You can use it for overall response and assessment of any lesions. But remember, appearance of any new lesions at any situation, this means progressive disease, even if you have significant reduction of your target lesion. These are the standard RECIST criteria, and actually in the current years and in the last maybe 5 to 7 years, there are many debates about the RECIST criteria, and they found that it's near to be modified. And usually already established a new criteria for a specific tumor. So RECIST criteria could be applied for most of the tumors except those. Malignant lymphoma, usually they use Lugano criteria. Gastric tumor, usually used QA criteria. And the hepatocellular carcinoma use modified RECIST criteria, and the mesothelioma used modified RECIST criteria. So when you're facing tumor like this, RECIST criteria will not be applied. Future trends for RECIST criteria address that so it might be time to move from anatomic unidimensional assessment or volumetric assessment to add the functional assessment of the tumor cells, including PET-CT. However, the availability of the PET-CT or PET-MRI, this is make a limitation to make a wide acceptance. In conclusion, RECIST guideline latest version is essential in day-to-day cancer, especially in the clinical trials, especially in assessment of any drug lesion. This is the cornerstone of the whole international drug companies to, in the phase 3 clinical trial, to establish their drugs and to become to market using these RECIST criteria. However, the further standardization is needed for functional imaging and the volumetric imaging tools to be considered for the routine methods of tumor response assessment. And thank you.